Good morning. I call this informational hearing for Human Services Finance to order. Members, this is informational hearing. There'll be no actions taken today. We have got a couple of agenda items, and Chair Hoffman is leading another committee hearing right now. He's going to join us shortly, as soon as possible, so he'll be here shortly. I just wanted to allow members just to quickly introduce themselves, and we will get to the informational hearing as soon as possible. And also those who are on Zoom, you'll have just to announce your name to make sure that we recognize you, that you're joining us via Zoom. We'll start from the right side. I see Representative Kwam.
Thank you, Mr. Chair. Representative Dwayne Kwam.
Thank you, Representative Don Gilman.
Representative Mary Franson.
Vice Chair, Representative Kristen Bonner.
Representative Peter Fisher.
Chair Noor here. And those who are joining us via Zoom, please announce yourself. We can't hear you. I don't know if you're able to hear us. Representative Keel, can you hear us? Senator Ebler, are you able to hear us? As you can see, we always have some technical issues trying to make sure that everything works well. Senator Ebler. I think they've been muted by the system, so. I think they can hear us loud and clear. And for that, we'll dive into the main discussion. To the members of the public, and I'm sure you're aware of the Healthcare Renewal process that we've been going through. We've had an extensive discussion about this issue. This is something that is so close to all of us. We wanted to make sure that no one who's eligible for Minnesota Healthcare Program loses their coverage. As you've had in the month of July, there was more than 35,000 individuals who were unable to renew for various circumstances, and then we rolled them over to August, and we have about 56,000 who now in the month of August combined, I believe. We'll hear more about that. Without further ado, I just wanted to welcome the Interim Assistant Commissioner for Healthcare, Ms. Marquardt. Welcome to the committee. Please introduce yourself and proceed with the testimony.
Good morning, Mr. Chair, and thank you. As you indicated, I am Julie Marquardt. I'm the Interim Assistant Commissioner and State Medicaid Director at the Department of Human Services. Just a little bit of background to remind folks of how we got here and what this is all about, because it's a course of several years. So remembering back to March of 2020, DHS, Minnesota, like all states, maintained health coverage for people under our public health care programs in response to the COVID-19 pandemic. Since then, we've had many people who have gained eligibility or came onto the program during that time. And they may have been eligible for Medicaid, which is medical assistance in Minnesota, or they may have been eligible for Minnesota Care, which is our basic health program. For people who came on during that time, we have kept them on. So when we often refer to that as continuous coverage. And there was a continuous coverage requirement that was passed and we maintained until this renewals process started. The continuous coverage really helped Minnesotans during a global pandemic. It made sure that people could get access to health care that they needed. We knew right away that COVID-19 was going to require people to seek care. And in order to keep people and each other healthy, we needed to make sure as many people as possible had coverage and could get the ready access to the care they needed. So during that time, there were about 360,000 more people that came onto our public programs during this time, and that's an increase of about 30%. So we now have 1.5 million people on our healthcare programs, and that used to be 1 in 5 residents in the state. It is now 1 in 4 residents in the state are on public healthcare programs. So when Congress passed the Consolidated Appropriations Act at the end of 2022, it ended the continuous coverage requirement, and that became effective March 31st of 2023. It required states to begin to resume their normal eligibility determination processes. So that is what the renewals process is the restarting of that process. Typically, and going forward, medical assistants and Minnesota Care enrollees will have their eligibility renewed once a year to ensure that they still qualify for the coverage. And that is the process that is referred to as a renewal. All 1.5 million Minnesotans that are on the program will need to go through this process before May of 2024. So that's the timeline that we have. As you indicated, Mr. Chair, maintaining coverage for eligible Minnesotans is a top priority for the state of Minnesota. We aim to have no one lose coverage who remains eligible for our programs. With that in mind, we've adopted a thoughtful approach, and we continue to evaluate and adapt as the renewals begin and as we go through them. I can tell you we are learning something every day about how to do this better, differently, what to stop doing, what to do more of, and we've initiated things we've never done before. This is an unprecedented event for us, and it's an unprecedented process for us to go through. So typically, medical assistance renewals occur throughout the year. So each month we're doing a group of individuals. So when we looked at Minnesota restarting our renewals, we divided our enrollees into 12 equal cohorts. So very similar to the process that we had historically used. And it was based on their initial enrollment month. The July and August cohorts, as you indicated, Mr. Chair, are currently in that redetermination phase. So they were the ones who went first. Those whose coverage would have ended July 1st and those whose coverage would have ended August 1st. Minnesota Care renewals occur all at one time, and that occurs in the fall for coverage effective January 1st. So the graph shows the estimated number of individuals that are in each of those 12, what we refer to as cohorts. And you can see the large spike that occurs in the fall, and that is, number one, it's the largest month for medical assistance, but that includes, of course, all the Minnesota Care renewals, so that accounts for much of that large spike. So talking about, as you mentioned, Mr. Chair, we extended the renewal deadlines for both the July and August cohorts. We had planned to start those cohorts for that first group would have originally ended July 1st. We extended their coverage for 1 month because, as you indicated, we were concerned about the number of people who we hadn't heard from. And so if we think about why we may not have heard from them, they've had coverage and we have continued to cover them without really a lot of interaction from us for about 3 years for some people. So a lot of time has passed, and people may have moved more than once. They could have moved and wouldn't have had a need to report their address. There was no need to be getting mail from us. Probably not the first thing on your mind when you're moving is, gosh, I'm gonna call and make sure my address is updated. So we knew that there was a large number of people who maybe hadn't gone through this before ever. We didn't know how to reach them. or we just out of practice, right? Like out of the habit of doing this. And so when we saw the numbers coming in higher than we wanted, we also knew that we were rolling out a lot of new things that we've never done before. And the group that went first, somebody has to go first. But it kind of stinks to go first because we're still trying things. We're still rolling things out, and they're not necessarily always getting the benefit of the best of that. And so giving them an additional month for us to keep doing and redoubling efforts and working with new partners really allows us a chance to try our best to reach them. And so in that time, when we gave that July extension, we did have thousands of individuals and family members that would have lost their coverage that did respond to us and submitted their paperwork. So that was a positive sign to say that some of the things we're trying are working, and we just need to keep trying and keep trying. And when we extend their coverage, that also means that the county and tribal eligibility workers, who are the ones who do the medical assistance renewals, it means fewer people that are coming into their offices while they're trying to do the next month's cohort. So we also have to balance the impact that we're doing to county workers and tribal workers so that we don't create these backlogs for them, because we need to make sure we can get the work done that we've got in the queue. It's also allowing us to look in real time what's happening. You know, are people responding? If we're making direct phone calls, are people answering their phone? Is that the best way to reach them? We tried texting. Is that working? And we can take that feedback and keep working it into our processes and sharing it with all the community partners, who I'll talk about later, that are really integral to this process. So we understand that this gives some enrollees some additional time, but this really is meant to a commitment to keeping people covered and to make sure that the people who find it hardest to interact with this process, that we're reaching them, we're offering assistance, we're making sure assistance is getting to them, so we don't exacerbate disparities during this process or as a result of this process. The other thing we are committed to is being as transparent as we can about what is happening, what we're seeing, what counties are telling us, what tribes are telling us, what community partners are telling us, ways we're trying to do better, and things that maybe didn't work, that we tried, but maybe they weren't as successful as we had hoped they'd be. So when we do these extensions, first and foremost, it keeps low-income families in Minnesota covered. It allows them to get health care that maybe they need that is ongoing. It reduces disruptions in that care. It reduces the disruption for providers who may be seeing patients that if they lose their coverage, that care gets disrupted, the providers having to react to that, the patients having to react to that. As I indicated, this has an impact on counties, tribes, and the state workforce. We rely on counties and tribes to do the medical assistance renewals. This is a lot of work for them. They've lost some of their workforce. The state processes all of the Minnesota care renewals. We've lost workforce during this time. And so some of this is allowing all of us time to replenish our workforces, retrain some people, and be prepared that there could be long hours for some of these individuals and have the means to pay overtime when that becomes necessary. It has impacts on our health plans. We have 9 contracted health plans that cover services for about 85% of the public program population. So when we make changes, we need to make sure they know what's happening. They are helping us reach out to folks. Provider organizations, we want them to be aware of what's going on so that they're prepared to help us too. Particularly, we've been interacting with pharmacies in the state. That's one of the first points of care where if someone's lost coverage, that may be one of the first places that is experienced and gets exposed. And then we've had community organizations who are trying to help people in their communities navigate this process. And it's not the easiest process. And it's not just second nature to most people. So making sure that we're explaining things in ways that people can understand what they need to do and that they can take the action that's necessary to take. There is, of course, if we extend coverage, there is an impact financially. We won't know until we're further along how the forecast is really going to shake out. However, the forecast did anticipate staggering the renewals. It anticipated churn. So when we extend coverage, we're impacting some of those pieces, but we're also, we also have provisions in place that allow retroactive coverage. So all of that has to kind of shake out before we can figure out how much did this cost and how much was offset by other savings. And so we'll continue to inform and update as we go along, and I'm sure we will probably be informing the November forecast with what we know at that time. And there has been a lot of attention placed on the national landscape of what is happening in all states. The KFF renewal tracker, as they call it, Minnesota, you'll see, isn't up here yet because we have yet to report our first numbers. So some states started immediately. And it's difficult, I will just say, to compare states to one another. Each state is approaching this differently. States are taking different tactics in what they want to do. States have different capabilities in their systems. They have different ways of dealing with renewals. Some, it's all centralized, some are more distributed, like Minnesota. And so it kind of depends on the planning and the objectives. As I indicated at the outset, Minnesota has taken a more measured, cautious approach of ensuring that we're not leaving people behind. And so we will report our first numbers on August 8th will be what the results for our July cohort are, and we will update everybody at that time when we have those numbers, but Minnesota then will begin to show up on this particular tracker, as well as there are other sites that are also tracking this. As I indicated, this really is about a commitment to making sure people have access to the health care they need. An extremely important part is the investments from you all, and to make sure that we could make this process work, that it could work for Minnesotans, that we could reach all Minnesotans. And so there were a number of very important legislative appropriations that came. First and foremost, $36 million was provided to county and tribal nation processing entities to help them restore their staffing, to train their staff, to do outreach efforts. That money was available July 1st, and we recently distributed that money to those entities, so they have it now to be able to use in ways that they will find most effective in their communities, to work for their communities and reach their community members. And so it really is flexible funding for them to do what is necessary to make these renewals successful in their community. There were $3 million increase in the pool that pays navigators. Those are folks who assist people in completing their renewals, and a $1.96 million in supplemental funding to the navigator organizations. They also, in addition to helping people, will do outreach, provide information, so that gives them some additional important funding for them to do work to reach communities who may be hard to reach. There was $4.5 million to implement a temporary disregard of excess assets for people who are 65 and older, who are blind or who have a disability. So that removes one barrier from a group of vulnerable Minnesotans. There was $5 million to suspend the Minnesota Care premiums to ease their transition as well. So it would not be a barrier for people who may no longer qualify for medical assistance, but may find themselves qualifying for Minnesota Care, that the ability to pay the premium that first time would not be the barrier to them maintaining their coverage and being able to continue to access care. There was $23 million to our department for the additional administrative resources we need to make the changes to the system, to stand up new ways of interacting with people, to increase our staffing, and to pay overtime, because we know that happens. We have that even in our pre-pandemic world. There was always components of overtime that had to be paid when certain times of the year volumes would get high. And then finally, 1.8 million for systems funding, just to make some of the changes. And for us, the adaptations that we've had to make to extend renewals, things like that takes the work of our Minute partners as well. So this slide actually, it's
Assistant
funny
Commissioner,
because, go ahead.
We've got a lot of other
Okay.
discussions. I just wanted to quickly go through some of the other slides. I know some
Sure.
members have questions
Yep.
about the renewal process, and they wanted to ask. So we will, if you can quickly
will.
just go through. I know most of this information members have already received it, and if they have any question, they can. So you can go through quickly, please.
Yep. So this is just a slide that depicts, and it's a little bit outdated because we've even done more things since this slide, but it's really to show the different modalities that we're using to try to reach people. This is, in a pre-pandemic environment, we wouldn't be listing all of these things. They wouldn't have even existed before. The next slide is just some figures on the different touch points that we're making, and within those, just to know that when we're talking about 292,000 mailings, people are getting 3 different mailings. They might be getting 5 different text messages. They may be getting emails from their providers. They may be getting emails from their health plan. So there are lots of different ways we're trying to reach people, because some ways are more effective for different people and other ways are more effective for others. And then there's direct calling besides that. And then we're really partnering with communities and using all of their avenues to reach people through their social media channels, community events, all of that. The next one is slide is really just a summary of and I believe you all heard about this, the mitigation strategies that we worked with CMS to have. So I won't go through them all because I think you've heard them, but if you need more information, we can provide those to you. Again, the next one is just some of our innovative approaches, so things that we've stood up. We have a document upload, so somebody could complete their form, but rather than walking it in or mailing it in, they can actually electronically upload it. And we can get it to the county or tribe who needs to process it. We also created a renewal lookup tool. Most people don't remember what month they came onto the program. And so the ability to look up and expect, okay, I'm not hearing anything, but my renewal isn't due till next March, so I shouldn't be hearing anything. So I don't have to worry that I'm missing. So that people just have more information about when to expect things. We changed our envelope to try to make it more noticeable, let people know if you see this envelope with this blue dot that has that message on it, that is your important paperwork. Pay attention to it, open it, complete it, and get it back in as quickly as you can so that we avoid any lapses in coverage for you. Partnership, we don't do this alone at all. We don't even claim to be doing it alone. But what's been really great is we've developed toolkits, and we've developed it in partnership with all of the parties that we're working with, and it really becomes a plug-and-play kind of informational thing where they can take the messages, take the different tactics, and use them with their branding, with their materials that they may be going to a school event or something. They can take all of these materials and put them into methods that they want to use that they think will be effective to reach families in Minnesota. We have been training. We continue to have bi-weekly roundtables. We have regular communication with our managed care organizations, and then we're coordinating with other state agencies as well. So this has really been an all hands on deck. I don't think I don't think we've ever had the state so aware that this process actually existed. It probably was quietly always happening and nobody knew. So we also are, as I said, committed to transparency. We have been working to make sure that we're getting it out into all media throughout the state, and we are very grateful for the efforts of all our media outlets that have really been helping us amplify that message. Again, we're going to continue to keep everybody up to date. We're going to provide the figures as they come in. We are using some of the lessons from COVID and from vaccine distribution. We are using the areas that have social vulnerability, and we are trying to target outreach in those areas because we know disproportionately, just like vaccines, this is a group who might not get their mail, who might not know what to do when they get that renewal, and may need help but don't know how to access the help to complete the renewal. So we want to make sure we're targeting areas that we know historically have disproportionately been left behind or tend to have lapses in their coverage. We've been working with community organizations. We've had equity forums. We have had great support from community organizations, and they're bringing forward really great ideas. We're translating materials into 5 different languages: Spanish, Hmong, Somali, Vietnamese, and Russian. And we are continuing to engage with new partners every week. So we are open to anybody who wants to work with us. And then finally, just leaving you with a list of what you can do. So if individuals are contacting you saying, what can we do? We're on Minnesota Care or we're on medical assistance. What do they need to do? This is the list of things that we are really pushing out there of ways that people need to act. And with that, I will end.
Thank you so much for the presentation. As I noted earlier on, this is a very important issue for us. As I always say, when you see the blue, it's time to renew. So there's a big blue circle on that. So I've been telling folks, when you see the blue, make sure that you respond to it. And quite frankly, I think for those who may end up losing their coverage, they have an opportunity to re-enroll within the first 3 months in order to have coverage pick up from where they left. So that is the process. And if not, they can always come back and reapply as a new applicant. Will allow my members who, Vice Chair Banner has got a question. Go ahead.
Thank you. First, I want to say thank you for a really comprehensive plan of multiple avenues of outreach to meet people where they are, to put it in accessible formats, to address folks with disabilities and things like that who may have extra challenges in this process. So I really appreciate that. I did have a question on the renewals, and we talked a little bit about the additional month of time in order to, give those first couple cohorts some times to work through some of the kinks, and of course, to be able to reach them. Have we found that additional month has been helping? Do we have any numbers or facts or figures around like how many more folks we've been able to reach in that extra month, or any of that, or strategies that we found were really effective by giving that extra month that we could leverage to help us get to more of those folks going forward?
Mr. Chair?
Obviously, there's some
It's a 16-bit sampled sound with a piano. So.
Assistant Commissioner.
Yeah, Mr. Chair, yes, so those renewals are still being processed as we speak. So those are still coming in, but we can report that thousands of people have responded during that additional month. So there is, that's a positive sign for us that people didn't just forget about it or say, oh, I don't need that coverage anymore. They just maybe didn't know, and finally some message got through. I will say that as far as what's effective and what we're finding effective, texting has been one of our most effective. We have never texted people before. This is the very first time, and we will keep doing it. These are things we're going to keep in our tool chest of things to do. I think the other thing that we have done is we have worked with our managed care organizations. We are working with our integrated health partnerships. We are working with our tribal partners to provide more specific data on who that they know is going to be losing coverage so that they can do direct outreach to them. Sometimes that call from your provider is the one you're going to answer, right? And so they can use tactics, and maybe it's different than if the state is calling you, you might not answer. But if your provider calls you, you might answer. Or that email. They have the ability to go through the electronic portals of someone's health record and say, hey, did you know your coverage is going to end if you don't do something? If you need help, call this, you know. And so those are things we've just stood up, but I think they are effective because they allow a more personal touch with somebody that's familiar.
Thank you.
Representative Kwong.
Thank you, Mr. Chair. It'd be nice if we actually had numbers and information. You made a determination to extend for a month because there was a great deal that you thought maybe weren't contacted because of disenrollment would have been large, but you never gave a percentage, although in your slides you have data on multiple states, and it would be real nice to actually have more than thousands give us the percentages so we know the effectiveness. And it'd be nice, you've got all these touch points, if you had an analysis of confirmed contacts, what percent, renewal, disenrollment, those type of things, so we see and project in the future which are the most effective. And then you also, in retrospect, can look and see these are much better for reaching people in this demographic, and et cetera, so we can improve. Because looking at the data that was actually provided, basically half of the states had enrollments of 60% or greater, so therefore they apparently aren't having the difficulties, and plagiarizing and copying success isn't a bad thing to do. But again, without actual data, it's hard for us to understand with precision instead of sort of general terms. So I'm hoping when you get some of that, you can pass it on to the committees so we actually can see that. The other thing is there any analysis on the effects and cost of AVR to your process? Both personnel and then actual dollars?
Assistant Commissioner.
Mr. Chair, so we definitely will share numbers. I know the chair did indicate at the outset, so I didn't repeat them. The numbers we did have were in July, 35,500 people that we hadn't heard from. And then in August, it was about 56,000. Those numbers change every day, and so we'll have, the final numbers, but it is kind of a moving target because renewals come in are processed as we go, but we will absolutely share the information. We are trying our best to track the effectiveness of phone calls. Many of those are being done by organizations that are not DHS, but we are going to try our best to get evaluation of that, because you're exactly right. I think we want to keep using the tactics that work best, and not every tactic works the same in every community. And so that definitely is part of the lessons learned that we want to take away from this as well. I don't have figures on AVR.
Representative Kwong.
Thank you, Mr. Chair. What I was looking for is actual percentages, because continuous coverage ended the end of March. So we've had a period of time, and you get renewal. Knowing, you obviously know numbers, you should be able to take the 45 seconds, whatever, to calculate percentages so we understand how many renewals and that type of thing. So I like data because we can make informed decisions, and I'm looking forward to actually seeing data in the future. Thank you.
Representative Quam, I think there's an excellent dashboard that you can review all this information. I'll send you the link. It's something that I usually take a look at and see where things are. So we do have a dashboard that we
Thank you, Mr. Chair. This committee meeting is not just for our
Perfect.
information, but it's also for the public. And it'd be nice for the public to really see a better picture. But I would welcome that additional link and information. Thank you.
It's available for the public, Representative Quam. I think we'll share that. We'll post it so that people can follow through the process. And by August 8, when we know exactly how many individuals may end up losing their coverage, that is not the end all. They still have a time to renew. So numbers will be changing frequently. But our hope is anyone who's eligible should never lose coverage. We don't want to be at 82%. That is extremely high. So we want to make sure that we provide care to those most vulnerable individuals, especially those who are homeless, those who have got limited English proficiency, those who are highly mobile. So we know there's a specific group. Assistant Commissioner, you mentioned the SVI. That is a critical component. I'm hoping that we will do more outreach by door knocking in specific areas to make sure that people are aware of. The challenge is, when are they going to renew? So you may end up talking to a person, they may not know when. So it may happen at the end, or it may have happened at the beginning. So I think that's the challenge. As I talk to folks, many people may not be aware of. Representative Gilman.
Thank you, Chair. So I have a quick question for the Assistant Commissioner here. So when the 30% increase happened, so I think you said 360,000 more individuals were offered the program. I would just be curious on how many months that took and how effective was the outreach then, and what did you do that worked then to help people during that critical time?
Assistant Commissioner.
Mr. Chair, so I don't know that we did a great deal of outreach at that time, other than more of our traditional, we'd have it on our website, we'd share it with community partners, and I'd say it was more of our typical. We weren't texting anybody, we weren't doing phone calls, we weren't figuring out, if somebody came to a provider and they didn't have coverage, that provider may have known to refer them to a navigator or something, So it probably acted much more like our typical pre-pandemic awareness. It didn't look anything like this does, I can tell you that. And the 360,000 occurred over a 3-year period. But I will say, as you can imagine, that when the contraction around the economy with things being shut down, or businesses perhaps seeing their business decrease as a result of social distancing, things like that, those would have been when we saw the biggest increases come on.
Representative Gilman, any follow-up?
Yep, one quick follow-up. So again, I think that's really great. So you think about how many people then were eligible at that time. And I think there was a big message, throughout the state too, that things would be available. So it was probably talked about in other ways, that people were just more notified because they were maybe both parents were out of work, or one was out of work, and that their income significantly changed. So I just want to make sure that we are also focusing on, of that, increase and that uptick during that time, people may have lost eligibility because they are now potentially back to work, right? And so I just hope, as well as that, we just speak to that if people are outside of that window and they've lost eligibility, they're still receiving that benefit. Because they were both, maybe there we go.
There's an echo coming back from the Zoom, so I think the technicians can help us there.
So I just want to make sure that we are also focusing on of that, it's so nice to hear my voice. Ooh. I have to have a more chipper voice. So I'm grateful for this information, but I also am just, I think for Minnesotans as well, if 1 in 4 right now are on the program, we might see it go back to 1 in 5 because we are, spurring on our economy and we're back at living healthy. And so I'm grateful for that too. So thanks.
Thank you, Representative Gilmore. I think there's also an opportunity for folks who are no longer eligible for medical assistance to move to Minnesota Care or into the market MinSure process where they can pay for their premiums and continue to gain coverage. Any other question for those who are joining us via Zoom? Any question?
I see no hands up. I think we did the official switchover on the Zoom, right?
Yes, we'll be doing the Zoom because of that technical issue. We'll bring the Zoom to the people. I just wanted to say thank you to the department, to the counties, and also the community partners. This is a collaborative effort. We need all hands on deck in the next few months remaining to ensure that no eligible Minnesota who needs coverage, doesn't lose coverage. So we want to make sure that we provide that assistance. We'll keep on monitoring where we are, and hopefully members will get informed and updated where things stand as we see numbers going up or down or that change that is happening. So thank you so much, Assistant Commissioner, and to the department for all the great work.
Thank you, Mr. Chair.
We're moving to the second presentation. I know we're running a little bit late, so this is in regards to the small assisted living facilities, and we'll start with the Department of Health.
Did you want to bring Debbie down too?
And we also have Hennepin County, Ms. Ackman, and then we have a few others who will be joining in that process. Welcome to the joint hearing. Please introduce yourself for the record and proceed.
Thank you, Chair Knorr, Chair Hoffman. My name is Lindsay Krieger, and I am an Assistant Division Director within the Health Regulation Division at the Department of Health.
Thank you, Chair Knorr and Chair Hoffman. Eamon Schmitz, Legislative Liaison with Minnesota Department of Health.
So I'm just going to pause for a minute to have Eamon put up the slides. But while we do that, thank you for inviting me here today. I'm going to talk about assisted living licensure. We were here in December to give an update on assisted living licensure. At that time, we talked about a work group that we were going to be convening in regards to assisted living licensure and specifically small providers. So I want to give an update on that work. Thank you. All right, to get started, I'm just going to go back to the background of assisted living licensure. Assisted living licensure was passed in 2019 with broad bipartisan provider and stakeholder support. The support does not mean that there was full agreement on all the language, but it was lived with a language that we knew it would have to come back with and work on in the years ahead. The intent of assisted living licensure was to set consistent, clear expectations for providers and more protections for residents in this setting. In 2018, the Office of Legislative Auditor did put forth recommendations to have more clearly defined protections for residents in these settings. And what assisted living licensure does is combine housing with services with the home care to put the housing and the services together into one licensure, which helps with confusion as to who is responsible. Ultimately, one person is responsible for housing and services. So I wanted to provide some data. This was data that we provided in December, updated data. I apologize for the black. I don't know why the color switched. But anyways, in regards to assisted living licensure in Minnesota, the 7-county metro area you can see is a large amount of where assisted living facilities are located. We have about 72% of assisted livings here in the 7-county metro area and about 28% in the greater Minnesota area. This is a little bit of a shift of what we presented in December with the percentages being 70% and 30%. So very similar, but just a little bit different of a breakdown. We do have many different license types, and I'll go to the next slide here and you can see But we have two main license types here in Minnesota. One is assisted living facility and one is assisted living facility with dementia care. The dementia care is really an add-on in regards to some extra training and requirements for that dementia care related service. Being a provider with dementia care does not mean that that is only where residents who have a diagnosis of dementia can live. They can also live in an assisted living facility, but an assisted living facility with dementia care can have a secured memory care unit, and they can also advertise as having specialized in dementia care services. We also have a provisional assisted living facility and a provisional assisted living facility with dementia care. This is a facility who has granted or has been granted their license by the department. That provisional license is good for 1 year until we go out and survey the facility to deem them in substantial compliance to have that full license. So the slide just shows a little bit of a breakdown in regards to the numbers. I want to highlight here for the facilities of 10 and under, that is quite a large number here in the metro area of facilities that have the capacity size of 10 and under. So we have 1,226. This is a previous increase of 970 that we presented in December. Now, just for reference, if we look at where the facilities are and what the sizes are for greater Minnesota, you can see in that 10 and under category, there is only 94 of facilities size that are 10 and under in the greater Minnesota area. So the concentration of small assisted living facilities is greatest here in the 7-county metro area. Now, I also wanted to highlight what we have for capacity, license capacity here in Minnesota for assisted living facilities. The license capacity is currently just over 62,000. In regards to license capacity, does not mean that that's the total number of residents in the setting, but what settings are licensed for that they could provide services to. And for comparison, residents in in a nursing home setting, is roughly around 25,000. So you can see that there is a large amount of vulnerable adults that do live in the assisted living setting here in Minnesota. The majority being in that assisted living with dementia care size. Now, this slide is something that we talked about in December. We talked about MDH's commitment to continuing to provide information, education, and to help answer questions in regards to the assisted living licensure. We know that assisted living licensure is new, implemented during COVID, and so there's going to be a learning curve in regards to the licensure. So the department is committed and has committed over the last couple of years in regards to further education and information for providers to be successful with this license, which ultimately goes back to the residents who are receiving care in this setting. We talked in December in regards to setting up a work group to look at, are there any areas of concern with small providers? What can we learn from those areas of concern? What challenges are there? How can we move forward, understanding more about those concerns? So we did develop and are implementing conversations with DHS and many other consumer and provider stakeholders to explore modifications that might be needed to balance the rights of the residents with the concerns of the small providers. So I want to give just a little bit of an update on where we are with that work group. The work began in March of this year, and we currently have 31 work group members, which include representation from many different stakeholder groups, including provider organizations, small providers, consumer advocates, the Ombudsman's Office, DHS, some counties, the BELTS Board, the University of Minnesota, and the Department of Health. The reason that we have so many work group members is because we wanted to have a really robust conversation representing many different viewpoints, especially the small providers who play a really big part, and we wanted to hear from them specifically as to areas of concern that they have identified with this language. We really wanted to mitigate closures, discuss the challenging issues, and work together to develop recommended solutions. So it's important to the department that our action items is not just legislative in nature. What can we do to change any processes? What can we do to provide further education? What can we do to help with increased collaboration with the department, other sister agencies, and with the providers? So these work groups and these subgroup topics are looking at developing action plans that include language, policy updates, and process improvements. Now, the focus that we started with in March was for providers that had the capacity size of 5 or under. But we know that there was legislative language that was passed at the end of 2023 that really increased up this work to the capacity size of facilities of 10 or under. So we will be working to incorporate that in the following months, bringing next legislative session draft language and any other recommendations that we have as far as burdens identified for small providers. So initially, the identified areas of concern, I just wanted to highlight for you that the work group members have came up with. We have subgroups. We have worked on 4 subgroup topics up until this point, including the kitchen and food code. We're hearing of concerns in regards to implementation of the kitchen and food code requirements, licensing, inability to move a license from one location to another, especially if a small provider is renting a location. Reimbursements, how much waivered services are paying for the services being provided for the residents in these settings, and then also staff training. Now, this is work, and I'll highlight in just a minute where we are with this work, but we also have a second round that we are going to be doing starting in August, and we'll look at the next 4 topics, which include staffing, restraints, FGI, and closures. So as I just mentioned, the 4 subgroup topics initially that we looked at included reimbursement, licensing, kitchen and food code, and training. And what we really did is we wanted to identify problem statements. Can we put these challenging issues into a problem statement or a question that the group can further discuss with brainstorming on what is working well, what isn't working well, to develop ideas for solutions? We welcomed all ideas. Nothing was off the table in regards to what changes could be or should be recommended to be made. And we're working on developing action plans. And this is just a small screenshot of the action plans that we are developing for each of the subgroup topics. And this is something that you will hear more about in the coming months ahead and also in the 2024 legislative session. So some of the initial action plan ideas coming out of the work group include drafting legislative language, which was something that was passed in that 2023 language as to can we bring back draft legislative language next session. So we are working on that, including examples such as portability of the licenses and training for staff, mental health training, and kitchen and food code revisions, just to name a few. We're also working on developing ideas or training for providers and others regarding topics that have been identified. We're working closely with the Department of Human Services in regards to a deeper dive into reimbursement and waivers. And then increased communication and collaboration. Assisted living licensure is a license that is licensed by the Department of Health, but that does not mean that we don't also need to speak with other agencies, including DHS, and so working on that increased communication and collaboration. So, and finally, I'll wrap up just in regards to the next steps in MDH's continued commitment for this work. We continue to work with the subgroup topics identified. As I mentioned, we have 4 other topics that will be starting in August. We continue to develop and follow through on our action plans. The action plans are good only until they are stopped. The work is stopped. So the work will not stop here. The work will continue forward on those action plans to identify how we can move forward with what has been identified. We will continue collaboration with the work group members and the stakeholders. I can say the work group and the subgroups have been a very robust conversation with many different people at the table talking about really challenging issues in a collaborative approach, which is really good to see. And then finally, continued education and conversations to help support the balancing the resident needs and the provider's questions and concerns. And I started out by saying that in 2018, the OLA made recommendations as to how can we better have protections in place for the residents, but that does not mean that the protections and what is in statute should be something that the providers cannot implement. And so we're looking to balance that between the rights and the protections of the residents, but also how the providers can implement and make sure that they meet the regulations too. And that concludes my presentation, and I will pause here for any questions.
Thank you so much, Ms. Kruger. So I think we had put a moratorium on the small assisted living settings, and we are seeing a lot of requests of new licenses that are coming up. And I think from your slide, there was 256 additional licenses. Are they in compliance with the new rules under 144G? You know, can you give us a little bit of a sample who's applying for an assisted living licensure?
Sure. So Chair Noor, just to further clarify, the Department of Health does not have a moratorium on our licenses. It could be, if you're thinking about the Department of Human Services in moratorium. We do not have a moratorium on licenses for assisted living facilities. And so what we are seeing is that there is providers of all sizes, but a large majority of providers a size of the capacity of 10 or under that are applying for a license for an assisted living facility. And so they'll go through the application process. There are many different steps to the application process. When that license is issued, then they are able to go out and obtain a residence for that setting, and then within 1 year, the department needs to go out and survey that setting. So then at that time, the department will determine if the setting is substantially compliant to get that full license. And so what we are seeing coming through the door is licenses of all sizes, but the majority or a large majority of them are the small provider size.
Just wanted to clarify, if someone has got a single-family home with less than 4 residents capacity, are you saying that that license, anybody who applies for assisted living license, they will be able to receive the license but not the payment? Is that how the moratorium was drafted?
Sure. So Chair Noor, again, in regards to the moratorium, the Department of Health does not have a moratorium on licenses for assisted living specifically. So whoever would like to apply for an assisted living license with a capacity of 4 or under can do so. And then they will go through the application process. And during the application process, we will ensure that the licensing, the applicant meets all the licensing requirements to get that license. In regards to waivered services and payments, I would defer you to DHS. That is the area of their expertise and knowledge, and not the Department of Health.
I appreciate that. I think that falls under the customized living
Yes.
process. So that's something that I wanted to clarify. So for sure, we had put moratorium for those who are applying for customized living for under the 144G. So I'll have to review back and ask, maybe the department can give us a feedback. Do we have anyone from DHS, just to clarify that? I don't want to leave something hanging between presentations. And while the department is checking that, I've got a quick question from Representative Kwam.
Thank you, Mr. Chair. I'm just curious because you've picked 2 counties, and I understand why, but there have been some innovative things done in the Mankato and Olmsted areas along these lines over the last decade or so, and it might behoove looking for worst cases and best cases in the rest of the state for your analysis. Thank you.
Ms. Krug.
Chair Noor, Representative, I'm not sure if there was a question there. However, what I can say is that Hennepin County and St. Louis County were selected. Hennepin County has about 75% of the small residential providers in that county. St. Louis County was selected just because of the greater Minnesota aspect of that county, but I completely agree with you. And any other input that we can have from other counties is definitely welcomed.
any further questions? Representative Gilman.
Jassy.
So just a real quick comment. I mean, I know that the sound is an issue for our Zoom folks, so I just encourage them to go on the main Senate page. So are you going to be sticking around in case we have a couple of members that might have some questions? Okay, awesome, thanks.
Well, thank you so much for your presentation. We'll now invite Hennepin County, Ms. Davy Ackerman, if you can come to the testify table, introduce yourself for the record, and proceed with your testimony once you're settled.
Do you want to talk about Mr. Chair?
Go ahead.
And thank you, Representative Gilman. There is, watching the behind the scenes, as Representative Gilman had just said, there's some issues with hearing and stuff, and people are trying to work on that. So one of the thoughts was there's some folks that want to testify, and we might end up going old school and have them call in on a cell phone and hold it up. But thanks for pointing that out. It's just, that's what was running around in the background. But I appreciate that. Hennepin County.
Thank you, Chair Hoffman and Chair Knorr and committee members for the opportunity to provide testimony from Hennepin County on the transition of small customized living to community residential settings. My name is Debbie Ackerman, and I am a Human Services Area Manager and Long-Term Services and Supports at Hennepin County. We're not seeing the presentation yet, so I'll just start by sharing what will be coming up on the slide when it shows the process to transition small customized living settings to community residential settings has many system interdependencies. The provider plays a key role in many of these interdependencies. Submission of licensing applications for both 245D licensing with DHS and community residential setting licensing with the county, scheduling fire marshal inspection and licensing visits, making corrections as needed to paperwork, items noted on the fire marshal inspection and/or licensing visit, and communication with people receiving services and their teams, which include the person's family, a guardian if applicable, case manager, and other interested parties. DHS needs to license the provider as a 245D provider. This licenses the services that are provided under the waiver programs. The county is responsible for the licensing of the community residential setting as a site. To minimize the duplication of work, it is advantageous to obtain the 245D license before the fire marshal inspection is scheduled and the community residential licensing study and visit is conducted. This is because the community residential setting must be inspected by a fire marshal within 12 months before the initial licensure of the setting. There's also the process to obtain a licensed bed under this moratorium. This is known as the moratorium exception process and requires that the person receiving services engages in person-centered planning and informed choice. Hennepin County's moratorium exception liaison works with the person's case manager to outline the informed choice process, and the case manager works with the person and their team. Once informed choice is confirmed, the moratorium exception liaison finalizes the paperwork with the provider and then submits it to the DHS moratorium exception liaison team. The DHS team approves the beds if they meet the moratorium exception criteria. The fire marshal inspection needs to be scheduled by the provider with the fire marshal. In some municipalities, there's a city fire marshal, and in others, the state fire marshal conducts the inspections. Wait times for fire marshal visits are outside of lead agency or DHS control. If a provider does not pass fire marshal inspection initially, the provider will need to make corrections and have those corrections approved by the fire marshal. Once the approved fire marshal inspection report has been received by the Hennepin County licensor, then the licensor can conduct their licensing study and visit. The provider may have corrections that result from this visit and will need to complete those corrections before they can be licensed as a community residential setting. So I think, now we have the slide with the interdependencies that I've been talking about. Once the licensing study is completed, the licensor sends in the paperwork to DHS to approve and finalize the community residential setting process, and they are now able to serve people under the waiver programs in a community residential setting. you want to move to the next slide. This slide shows an overview of the steps involved in the process for licensing and the transition of small customized livings to community residential settings. Hennepin County has recently updated our process to accommodate the submission of the moratorium exception request form before 245D licensure is obtained to meet the December 31st, 2023 deadline. The initial step in the process is for the customized living provider to inquire about a transition to community residential setting. Hennepin County will work with the provider to determine if they meet eligibility and moratorium exception criteria for the transition from a customized living to community residential setting. If the provider is not yet licensed as a 245D provider for waiver services, the provider will be directed to apply with DHS for the 245D licensure. The moratorium exception process will also begin at this time to get the required forms from the provider and begin the person-centered planning process with the person. After receiving the forms from the case manager that confirm the person-centered process and informed choice, the county submits the moratorium exception form to DHS moratorium exceptions team to obtain the beds for CRS licensure. Once the 245D license has been approved by DHS and the licensed beds have been approved by the moratorium exception team, the provider submits the application for community residential setting licensure to Hennepin County. A licensor is assigned and the provider will schedule inspection with the fire marshal. The Hennepin County licensor attends the fire inspection to support the process. After receiving the approved fire inspection report, the licensor can complete the site visit and licensing paperwork. Once all corrections from the site visit have been completed, the paperwork is then submitted to DHS for processing and approval. After DHS approval is obtained, the provider can begin to serve people with community residential services in this setting. So you see all of the different pieces of this slide are sometimes working in parallel, sometimes working in a linear process, and are all a key piece to being able to transition to a community residential setting. Some process considerations and adjustments that Hennepin County has made. We recently adjusted our process to submit the moratorium exception request before the provider is licensed as a 245D provider. This was in response to the recent legislation. We are committed to timely licensing within the parameters of the system interdependencies that I just spoke about. We have heard concerns from providers about the length of time it takes to become fully licensed to serve people with community residential services in a community residential setting. We process paperwork, assign licensors, and schedule site visits to support our part of the process in an efficient and timely manner. Hennepin County has considered adjusting our practice to complete the community residential setting licensing visit before the 245D license is obtained. At this time, we have determined we will not be adjusting this practice due to the concern that if there's too much of a gap between the fire marshal inspection, the community residential study visit, and obtaining the 245D licensure from DHS, that we may need to require another visit with both the fire marshal and CRS study. And we have concerns about the length of wait times for the fire marshal and capacity for our licensors. Our goal in all of this is to ensure resident safety, integrity of the site study. We have added positions to support communication, tracking, and follow-up with providers and partners to keep things moving along in the process. We know that in Hennepin County, there are hundreds of potentially eligible customized living settings that could transition to community residential settings under this moratorium exception. We have completed the process for 18 settings that are now licensed as community residential settings. We have 132 settings that are currently in a transition process. As you'll see on this slide, we've identified that 95 of the settings in the process are awaiting a provider response. The vast majority are at the very beginning of the process, and we are waiting for the provider to complete the moratorium exception bed forms that initiates the process for starting the informed choice. Other provider responses that we are needing to wait in order to proceed include waiting for the community residential setting licensing application and corrections that need to be completed after the fire inspection or the licensing site visit. Where you see on the slide the informed choice process, we have 25 settings that are in the informed choice process, and that means we are waiting for the case manager to conduct person-centered planning with their person and their family. 11 settings are currently waiting for the provider to be licensed under 245D, and we have 1 setting that is on the list waiting for fire inspection.
Ms. Ackerman, on the 245D, what's the length of time that you're seeing waiting for the licensing on that?
Thank you, Chair. I'll need to defer to DHS for information about the length of time they are at now.
No, that's fine, Ms. Ackerman. We know that, statutory language is one thing, but because of the staff capacity in which we tried to address this past session as a group here between the House and the Senate, and we know that that was one of the issues. It's just really, it's interesting to see that these various points that you're drawing in, and I know the process that Hennepin County did. Our CA for the Senate CA for the 2 committees here actually went and did a process, sat through the process with a provider, and Hennepin County, you got a lot of work to do, but you did it well. And so it's just sad to see that there's so much backlog going on, and that's a concern to me. So thank you for that.
And Chair Hoffman, I think the department will be here just to respond to that. And also, is there a need for waiting for that 245D? And how long does it take for that whole process? I think there was a conversation, and we passed legislation that the transition can happen because we've got a short period of time by December, and many people will not do the transition without the 245D. And I know many providers have been told, unless you have 245D, you cannot transition. So I think that is a clarifying issue for the department to come and clarify, because we don't want to be discussing these issues without having that clarity. We passed the legislation to streamline the process, to expedite the transition from a small assisted living licensure to the CRS. So I think we have the team coming up while you're still sitting there. Maybe they can provide clarity to that.
And Chair Knorr, if I may.
Please proceed.
As our colleagues from DHS are arriving, I would like to say, and it's further in our presentation, the moratorium exception beds are what need to be completed by December 31st of 2023. And so, as I mentioned, we have adjusted our process, and we used to previously wait until the 245D license had been obtained before we submitted the 6021, which is the form that goes to DHS. We have now adjusted that process, so we are able to obtain the beds through the moratorium exception process. What we're working through in our process to adjust is and make sure that we're committed to providers, that the informed choice process is still a big piece of that, and so we will need providers to be working with case managers, people receiving services, to complete that in a timely manner. But my understanding from our colleagues at DHS is that as long as we have that moratorium exception bed approved by December 31st, even with a delay in 245D licensing, we can still continue with the process of getting them licensed as a CRS once that 245D has been obtained.
Thank you. To DHS, please introduce yourself for the record and proceed.
Good morning. Thank you, Chair Knorr and members of the committee. My name is Alyssa Dotson, and I am the Deputy Inspector General for the Licensing Division within DHS. Would you mind clarifying the specific question for me? There was a few questions there.
I think the question is transitioning completely to the CRS without the delay of the 245D. We know it's going to take a long time. So we wanted to clarify, because we also passed the legislation giving the authority to the commissioner to determine, that process. So if you can provide us a clarity so that every county applies the process equally, and also understanding what's next.
Thank you, Chair. Yes, the 245D license needs to be in place before they can begin providing those services. As long as they have applied and are in line in the application line prior to that December 31st, they will qualify for that moratorium exception. They don't have to have their license in place by December 31st for that time. So we are working through, as you're well aware, we have a long line of applications and some delay in processing, and are grateful for the additional resources that were allocated to us this last session to begin hiring some additional staff to work on that. But we are working through those applications as they are coming to us, and are, as long as they are in line in that have submitted their application to us by December 31st, they will qualify for that moratorium exception.
Just wanted to clarify. I know we put some language that is more of in line with giving the authority to the commissioner, that you can take away or give the license if things have not moved further in the process. I just wanted to make sure that we're clear. Those who are still waiting 245D, we don't know how long. We want to have clarity, we want to clarify how long will it take for folks to transition, even if it's after December, because it's one of the inhibiting issue for many folks to making that decision of transitioning. If we don't need a 245D, if they can be grandfathered in, all that authority is within the department, and we're hoping that there's some sense of urgency of now to make sure that all those things that are being cleared by the county, that the state can take over and be able to process it in a short time or period, so that we can transition folks. That's our expectation, and that's our hope, and I'm hoping that we can get some detailed information of what needs to be done.
Sure. Thank you, Claire Nauer. And we can certainly follow up with, detailed information about the application process. There's not a grandfathering in if they hold an MDH license that they would automatically get granted the DHS license. They still have to go through the application process and go through all the, necessary requirements to get that 245D license. And so some of that is dependent on the provider getting back to us and walking through that process on how quickly that moves as well. And so the timeline from when we grab the application to when the application is or the license is granted varies dependent on each provider, their knowledge of the license, their service, their if they've gone through the steps of informed choice and some of these things. So it does vary greatly based on their ability or their knowledge. Some of these providers also currently do hold a 245D license for other services. And so they would not have to apply for a new 245D license if they already have a 245D license. And so those ones we can move along much quicker.
Thank you. So as you're thinking about this for next session, I think, Ms. Ackerman, one of the things is lots of discussion about what do we need to help fix these gaps. I mean, this is why we're having this conversation today, because there's multiple gaps as we even look at children's behavioral health and decompression. And we still have some more conversations regarding, what I see as a scary scene. There was a city west of us that, decided to pull a licensing, a rental license, and I think that's an issue there. There's some other things. But as you're looking at this and knowing you understand how the system works, it's really all of us on this committee would benefit from having you come with us with what you see as the fix, right? Or if you're part of that conversation, I would love to see the department. And I love it when we did our conference, we were the only conference committee not to exchange offers. All these years, Representative Quam, it's always the history of exchanging offers, right? And the House and the Senate in Human Services didn't exchange offers. We broke up into small groups and had discussion, and it worked, right? And it's like, we see this here too, because we're all focused on problem solving for, in this case, we're charged for the most vulnerable people in the state of Minnesota, right? That's our due diligence relies on that. So however you could utilize, those in the success stories that if Mankato has got some stuff that's going on, let's get it up here. Let's get something working here. So I appreciate you being here and appreciate your time on that. So sorry, Mr. Chair, I just, we should have done 4 hours on this meeting because this is good stuff, right? Thank you.
Ms. Ackerman, please proceed. Sorry about the interruption. I know we have a lot of questions.
Apologize to me about it.
Thank you, Chair Noor. As Ms. Dotson mentioned with the department appreciating the money, Hennepin County does appreciate the money that was allocated to us in this past legislative session to support the timely licensing of providers transitioning from customized living to community residential setting under this moratorium exception. We are working with DHS to develop contract language around outcomes and payment for this allocation. And we have a number of positions that have been hired or soon will be hired to support the transition process, as well as ensure ongoing licensing capacity for these settings. These positions include 4 limited duration positions. In Hennepin County, these limited duration positions are hired for up to 2 years, and they were identified to support the transitions under this moratorium and ensure that we meet the statutory timelines for transition activities. The limited duration positions include 2 licensors as well as 2 support positions for planning, coordination, and communication. As we mentioned earlier, the number of system interdependencies requires a lot of tracking, communication with providers, communication with people served, communication with the Department of Human Services, as well as the fire marshal. We have also begun the process of hiring 2 licensors for permanent positions that will support the ongoing licensing of community residential settings and adult foster care in Hennepin County due to the increased number of community residential settings that we anticipate because of this moratorium exception. Hennepin County Long-Term Services and Supports is committed to supporting providers during the customized living to community residential setting transition. We will communicate process and procedure updates on the moratorium exception submission to providers to ensure that they have time to complete the informed choice process and return the paperwork to us before the December 31st, 2023 deadline, when we need to have documentation submitted to DHS. We will ensure that we work closely with DHS to seek clarity and support as needed throughout this process. We appreciate the opportunity to be here, and I'm open to any questions that the committee or chairs may have.
Well, thank you. Any questions from the members online? Just want to thank the county for taking on this, because majority of those small customized living within the county. So we're hoping we can provide you the support because we care about the individuals, the most vulnerable individuals that many people are caring for. Mr. Chair, do you have any questions before we proceed to the last?
No, Mr. Chair, I appreciate it. This just really isolates what we know we're working on, and just want to see that collaborative work going, because, again, focuses on finding the best results for the people that we're supposed to be serving, right? So thank you for your time.
Thank you.
I have Michelle and also Lisa Papp-Richards, if you can join us and briefly.
This is online, I think, with Larry, right?
Yes. Please introduce yourself for the record and proceed.
Yes, my name is Suzanne Scheller. I am the legal advisor for Elder Voice Advocates, and thank you, Chair Knorr, and members of the committee for allowing me to be here. I'm continuing on the theme of gaps in the law and vulnerable adults, which is why we're here. And so I am highlighting an issue that has been known. In 2019, we had assisted living licensure that was created, and at that time, we had the intersection of HUD settings, subsidized housing settings that were intersecting with our care and services, and we at that point in time accepted our HUD settings from the need for assisted living licensure. And I am here to say I believe that we need to tackle that gap in the law. And so I'm highlighting the issue as a member of Elder Voice Advocates. The HUD settings include those such as Section 202 for older adults and Section 811 for adults living with disabilities, and other project-based and Section 8 voucher settings. There has been discussion on this issue, but we haven't got to solutions and action, and that's what we're really calling for here is a commitment to that during this legislative session.
I'm highlighting the issue as a member
and so if we look at our definitions, and I'll keep going, you know.
1 second, I think
for adults living with disabilities,
we may just want to have to give up on that online setting. Please proceed.
Certainly. When we look at our definitions in 144G.08, in subdivision 7 as well as in subdivision 9, we define assisted living facilities. There are a series of subdivisions that are accepted from that. Those are the HUD settings we're talking about, and we define assisted living services. Residents living in HUD settings that may otherwise meet the definition of assisted living facility do not need to be licensed. So the result is neither the Minnesota Department of Health nor the Department of Human Services are completely aware of whether such HUD properties are providing assisted living service, given there is no license application required. There's not a registration to exist to notify or license to notify the public of vulnerable adults being served in those settings. There's not regulation and oversight from state agencies that is occurring. And notably, the termination of lease and services is not coordinated, so that when these residents are displaced, and we will have testimony about that, there is not a coordination of services to allow them to find a new setting for those services. There are approximately 1,000 HUD settings in Minnesota. Approximately 485 of those are for those aged 62 or older living with disabilities. That's Section 202, and another approximate 116 of those are Section 11, those living with disabilities. The number of vulnerable adults living in these settings is not insignificant. So we do believe that this gap, leaving our vulnerable adult most exposed, is important to fix. And this issue was brought to light recently in Bemidji, Minnesota, July 6th, when Red Pine Estates residence, a HUD-owned property, was suddenly closed due to structural concerns. Many older and vulnerable adults lived in the building, yet when they were displaced, the protections and oversight afforded by the assisted living license law were absent, leaving residents and tenants to largely fend for themselves in some instances. 28 of the 47 residents in the building are believed to have been receiving county services. We know of many who were receiving home care and PCA services that needed to continue after that building was closed. But we did not have assisted living law in place. We did not have the regulation and oversight to address those vulnerable adults. I have personally talked with many of the tenants in Red Pine Estates building, 91, 95, older adults needing services. It is an important issue for them, and they are trying to manage as best they can in a very difficult situation. Had assisted living license been in place, it is believed that greater coordination could have been facilitated to assist these residents in finding alternative housing and continued services through the Minnesota Department of Health or the Department of Human Services. I believe there is testimony here from one of the many volunteers assisting Red Pine Estates to talk about the impact of the immediate removal of vulnerable adults from their home. I will conclude my remarks here by stating that Elder Voice Advocates is deeply concerned about the impacts of 144G exempting HUD settings from needing to be licensed as assisted living. The Minnesota Elder Justice Center is believed to share those concerns, and other advocacy groups as well. Again, there's been conversation, but not action. We believe now is the time to fix that gap. And with that, I'll conclude, Chair Knorr, and allow Lisa Pratt-Richards to testify, unless there are questions.
Thank you so much. I don't know if Lisa Pratt-Richards can join us via Zoom. Are you able to present?
As well. Again, there's been conversation, but not action. We believe now is the time to fix that gap. And with that, I'll conclude.
Lisa, can you
Chair
mute
Knorr,
the
and
YouTube
allow
that you're
Lisa
listening to?
Pratt-Richards
Sorry about that.
to testify, unless there are questions.
Thank you so much. I don't know if Lisa Pratt-Richards can. Lisa, if you can mute the YouTube. Are you able to?
Can you hear me?
Yes, we can. Please
Can
proceed.
you, are you able to hear me?
Again,
Yes.
there's been conversation, but not action. We believe now is the time.
You can mute the YouTube hearing.
Sorry about that. To testify, unless there are questions.
Thank you so much. I don't know if Lisa Pratt-Richards can. Lisa, if you can mute the YouTube, are you able to?
Can you hear me?
Yes, we can. Please
Can
proceed.
you, are you able to hear me?
Yes.
Oops. Okay. If you can wave, maybe Senator Hoffman can wave at me because I can't hear anything. Okay. All right, thank you very much. All of the stuff that Susie said needs to happen. I'm going to do this in a nutshell because I can't hear myself speak. But we have a total of 19 residents that are left to be placed somewhere. When I got the call on June 30th, there was no help for these people at all. None whatsoever. We asked to have the Red Cross called in. The Red Cross has yet to be called in to help us. And it's our understanding that that Red Cross call needs to come from our chief of police, the sheriff, or the our fire chief. But what I want to get to that I feel is so important is our vulnerable adults here. A lot of these people, like Susie said, need to be helped. We have one lady that ended up spending 14 days in the hospital due to lack of people checking on her, county going in, checking on her. After she got out of the hospital, then she went back and spent another 4 days in the hospital in a coma. We have another gentleman who is a veteran that is now in a Super 8 hotel. He has 3 different types of cancers. He has stage 3 bladder cancer, stage 4 colon cancer. He has COPD, end-stage heart failure, and emphysema. He signed a DNR the other day, and he's not going to make it. One of the things he said is that he would like us to make sure that his wife was okay. When we arrived on the scene up to Red Pine Estate, it was a disaster. We got no help from anybody. Thank God for us strong 6 women. We did the best that we can. On Wednesday, the county showed up, but they did nothing for us, and they were pulled out of the building because the building was unsafe. We continue to struggle to find housing for these people, but we're not having any luck. This is the 4th building in Bemidji that has been shut down within 2 years. I believe it's like 127 residents that have been displaced. And this just keeps getting worse and worse and worse. I guess the vulnerable adults, these residents get services, but nobody's been coming in to help them. Even now, mental health is huge. These people don't know if where they're going to sleep tomorrow because we are on, we have them in a hotel and funding is getting shorter and shorter for them. I don't know what to say. It's a passion for me. I'm grateful. The first thing I did though is what I reached out to Elder Voices and said, help me, tell me where I need to go. Who can we get to help with all this stuff? And so with the guidance of Elder Voices, we've been doing the best we can. We have some residents that have been placed, some that haven't. We have 14 residents that are missing, that we have no idea where they went. They, could be couch surfing. They could, wherever they're missing. But I think with all of this moving forward, we need to have some guidelines for these places. They don't have any. There is no social activity for these places. I just talked to a resident today. There's no activities. There's no getting them to appointments. Nobody checks on them. Like that one lady, Virginia, she'd been in her apartment for over a month. Or no, I take it back, over a year. She got a new case manager in January, and that case manager had never checked on her. And when we went into her apartment room, they wanted us to have hazmat suits. So if we could get some new guidelines, rules, regulations for these people, it would be greatly, greatly accepted. I know I'm kind of all over the place. But one thing I need, and Senator Hoffman, if you can help me with this, I need to have a place for Ron to go. Ron is a veteran. I don't want him to be dying in a hotel room. I need a place for him and his wife to go so that he can spend the rest of his life. You know, he did his job for our country. Now let's step up the plate and do something with him. You have my phone number, call me. I want to have a chit chat with you. And if you guys need any documentation, please let me know, because I'm going to tell you one thing. The stuff that has been reported in the paper of agencies helping us is not true. And one thing I've learned when I've come to you to testify before and working with Susie is that if I'm going to say something, it has to be true. And I can document everything I'm saying. And with these other women that we're working together, we have a timeline. We're working our butts off. Someone needs to help us. And also, tell me who makes that call to the Red Cross to help. Because we called the Red Cross, and the Red Cross said that this call needs to come from the mayor, the fire chief, or the sheriff's office. Nobody's did that. And I got that directly from HUD yesterday. They said a phone call should have been made to the Red Cross, and we're still waiting. So thank you for this time, and please reach out to me and help me with Ron. Thank you. I
Thank you so
appreciate it.
much. I know we're running short on time. We will have an extended time just to make sure that we cover everything. So, Larry, I know you do have a quick meeting coming up. If you can unmute Mr. McDonough and proceed with your testimony, please.
And then we can, if there's follow-up with Ms. Scheller, she wants to stay, because the gap that exists right there, that's absolutely, my heart just hit the floor, you guys, on Larry. And it was my assumption that Beltrami County was actually at there. So a follow-up, Mr. Burdick, maybe later we'll have a conversation on, so I appreciate. Thank you, Ms. Scheller, for bringing this to light. And members, I had passed out her letter, which really explains that, the gap that's there. And I look forward to how do we get that, Mr. Chair, that HUD settings needing to be licensed as assisted living settings. I mean, that's really the heart of the matter there on this one. It's like, because there is a responsibility we have. These are most vulnerable people. Larry should not be wording. So anyway, with that, Mr. Chair, and thank you, Ms. Scheller.
Thank you.
Mr. McDonough, please proceed.
Hi, my name's Larry McDonough. I'm on Zoom here, and I think I'm ready to speak now. There is a lag on YouTube Live, so it's a little bit hard to know when is my time. So hopefully someone will flag me if I should not be talking now. So I'm an attorney with National Housing Law Project. I was a longtime legal aid attorney, and I practice in the area of housing. And I've been doing some work with both chairs on some legislation to deal with some of the issues with assisted licensure in the landlord-tenant setting. Those bills are Senate File 3048 and House File 3097. I became aware of the need for some legislation on these topics late last year. KSTP Television contacted me about their getting wind of some license, so different types of license, a city rental license revocation in New Hope for 2 group home facilities. And it turns out it was based on neighbor complaints for things as little as a resident made an unwelcome comment to me, or a resident threw a cup at a door inside of the facility. And the city of New Hope revoked that license and also revoked a license for another property as well. So the fixes that are in these bills are 2 things. And I also became aware of issues with landlord termination notices to care facilities that were renting space, not giving them enough time to relocate. it's also relevant to what's going on in Bemidji. So the bill has two things. One, if a city is going to revoke a rental license to a care facility, which is broadly defined, they would have to give notice to that facility, and also interested parties, which includes the ombudsman's offices and the attorney general and the state agency that regulates that care facility. And the care facility itself would also have to give a notice when it receives it to residents and people that care, help with those residents, like conservators and guardians. For instance, I'm a guardian for my adult daughter with special needs. And then any of those parties, if they wanted to challenge this, could file an action in court that would move very quickly, a little bit like the types of actions that landlords file against tenants or tenants file against landlords. And in that action, the court would then make a decision as to whether the city is kind of following law, and is it not violating any other laws? Is the care facility violating any laws? And to be able to issue a decision that meets the needs of both the city and the care facility and the residents as well. So that's one part. And the other part would require a landlord that wants to terminate lease to a care facility that they'd have to give a notice of that, and that notice would also go to the ombudsman's offices and the agency of the state that regulates that facility. And then the landlord would have to then wait while the state makes a determination on a closure plan by the care facility. So hopefully that would build a little more time and a little more process that would allow for if the facility really needs to close and the lease is going to get terminated, that there's more time to relocate people. And so neither of these, I think, directly address the fact that in Bemidji, that those properties are not licensed, and so they wouldn't fit the definition of care facility. I've now gotten some information on perhaps expanding the bill to include those types of properties, regardless of whether the exemption that's in current law gets removed or not. So I think that's it for my testimony. I'm not sure what the best way is to hear if I have any questions or not. So I think I'm going to mute myself here and go back to YouTube Live unless someone tells me something else.
Thank you so much. Professor, I think we have a lot of discussions on this, the House File 3097, Senate File 3048 that we introduced. I think it's really important that we talk about landlord-tenant rights when it comes to care facilities. So thank you so much. We'll have more conversation during the next session.
Thank you, Mr. Chair, and thank you, Professor McDonough. That bill that we talked, the professor was talking about, members, is I think in the off season here, as we're getting ready to throw that first pitch in February, really look at that gap because, again, coming back to what are we doing to make sure that the folks that we're supposed to be watching out for our services and providers we're doing this in a way that represents. And I like the term informed choices, right? That the Hennepin County, thank you for reminding us about informed choice. It's not just a word that can be used, but rather I believe there was a federal judge who said, where's informed choice? And hence what we did in Minnesota is we actually have a definition of informed choice. So with that, thank you. And Ms. Scheller, I look forward to continue to work with you on these gaps, and I know the department does as well. And Mr. McDonough, thank you. We're gonna keep this conversation going. Without further ado, I hate using that term, further ado. You're not supposed to do that when you're doing stuff. Any other questions from members? Any comments? So let's go on, and we ran up against the timeline, but this next discussion, folks, is really important, and it leads because here's what I hear, and this is what we've all heard, right? That there's a discussion they called hospital decompression, but really what it is why is it okay for a child to be left in a hospital for 12 months? Right? It's a question. It's a question on the table. Why is it okay for a hospital to be told that you can just dedicate a whole wing to one child? You know, why is it okay for that? Well, it's not okay, but that seems to be what's happening here, right? And it's not about pointing fingers or anything, but it's really about, we have some folks that want to talk to us about that issue. And I don't know if it makes sense to start, let's start with the Department of Human. Yeah, come on up, Christy and Natasha Mertz. If you could just give us a quick highlight, because there are folks from that I really think it would be benefit for us to hear from. Folks from the Children's Minnesota. We got North Memorial, Wendy Elferts, who happens to be from Dayton, Minnesota. It's Senate District 34, anybody who's tracking that. She's here. Dr. Patel. I mean, there's some people that are in the trenches on that to hopefully what this creates in Director, you're a director, right, Natasha? The new Alex Bartalik, or no, is that correct? No, I'm assistant commissioner. You're assistant commissioner now.
Mr. Chair, I was the director of the Disability Services Division for a minute.
I love it.
Now,
So can you kind of give us a highlight? I mean, we're up against noon. I know folks want to go, but yet I want to give some really good time here. And then I know Representative Hicks will have questions, clearly, coming on, and she's online, and we just want to make sure, given the fact that, the old phrase, Radio Shack, you got questions, we got answers. Well, maybe we should go back to Radio Shack to try to get us a system that actually works here. But Radio Shack's out of business, so that's supposed to be funny, Christy, and that's my wife reminds me I'm not funny. Don't try to be funny. So time is there. If you could just condense for us, Ms. Mertz, I appreciate it. Assistant Commissioner, welcome.
Thank you, Mr. Chair, Chair Knorr, members of the committee. My name is Natasha Merz, and I am the Assistant Commissioner for Aging and Disability Services at the Department of Human Services. And given the time constraints, I'm going to run over some of the main points in my presentation very quickly to leave room for other testifiers and any questions that this committee may have for the department. So just setting the stage here, we know that there is a very serious and significant problem going on in our hospitals, in inpatient units and emergency departments where children and adults, but I understand the focus today is adolescents and children, are stuck in the hospital without a viable and safe community-based discharge plan. Some of the factors driving this problem, not all of them, but some of them include unprecedented demand for mental health and behavioral health services. This problem has certainly always existed in Minnesota and other states, but certainly has been exacerbated by the pandemic, including workforce shortage and the lack of direct support professionals that are trained and equipped to support children with needs this complex. And obviously, we need to do a better job in our whole system aligning services and supports across the continuum of services to create those options. Want to just quickly mention some of the positive aspects of the 2023 legislative session that we are currently implementing that get at some parts of this issue. Partial reimbursements for hospitals for avoidable patient delays. You can see there, and I think in the interest of time, I'll keep us moving, but just wanted to highlight that there are some things in this session that we think will be helpful, and I will talk in a little more detail about the Acute Care Transitions Advisory Council in a minute here. Okay, so wanting to talk about how we think about the work at the department, recognizing that it has evolved since the COVID pandemic. So we and the Department of Health engaged in different activities during the pandemic called hospital decompression, where the goal really was to do whatever we could to get people moved out of acute care settings to create capacity for COVID patients and other people that needed acute care. One of the outcomes, or one of the outcomes of that was shining a brighter light on the persistent problem of people including youth, that are actually stuck in hospitals with no appropriate community-based placement. So we're really referring to this as acute care transition work, because it is not time-bound like hospital decompression work was, and really is about building a different or modifying our current system to better meet the needs of patients and people that are in these situations, to return to the appropriate level of care and to access the community-based service whenever that's possible and appropriate, as well as thinking about how do we prevent these situations when possible, and how do we avoid avoidable readmissions to the hospital with more robust focus on transition planning. So just sharing a kind of our working definition of stuck in the hospital. This certainly is nothing official about this, but this is just sort of how we're thinking about it, that people that are either did not have a hospital level of care need and were in the ED, or met their treatment goals, no longer need a hospital level of care, but there is no appropriate community-based placement for them. They've been denied by multiple providers. Often we see these folks have engaged in some type of self-injurious or aggression to others and harm, and that makes it very difficult to find appropriate placement, and often have received service terminations from existing providers and there's not a pool of providers to draw from. So I wanted to share the limited data that we have about what we know about this population, particularly of children and adults. And I'll say again, this data comes from some of the pilot work that we've been doing with Fairview that I'll mention in a minute through our hospital technical assistance and consultation team. So for looking at the children, which we're defining as under 20, often have engagement or connection with some type of child welfare investigation or system. We certainly see that Native American children are overrepresented in this population, and often autism or other types of neurodevelopmental delays are present. And again, talked about acute aggression. We also have found through this limited data set that there is a strong prevalence of trauma with these children and adults, that often there is traumatic experience in their background or formal PTSD or other types of trauma. We think that was playing a significant role in enhancing or exacerbating the complexity of the need and the support needs. Often these populations will have reputations within the provider community as being hard to serve, so they've burned bridges, and again, there's a much smaller pool of providers to draw from. And sometimes we're finding, especially for people that are identified as members of Black, Indigenous, or people of color, that they may be underserved. They may have very complex needs, but only have been receiving maybe personal care assistance or some of the more lighter touch services in the community, and that chronic underservice has led to the hospitalization. Often there are communication challenges. People don't use words to communicate, or communicating with them is more difficult. And dual mental health and intellectual disability diagnosis. So really thinking about kiddos and adults that span different service lines and are in mental health and disability services, and really needing to better integrate and allow people to get services from both areas and align that all in a support plan. And our system doesn't support the robustness right now with which that needs to happen to support complex needs like this. Why are people getting stuck? Certainly this is a multifaceted problem, and I think there is no easy one solution or one thing we can point at, but some of our preliminary learnings are, again, I've mentioned lack of provider capacity in psychiatric residential treatment facilities. Those beds are limited. Maybe the level of care the child needs isn't available or doesn't exist, so thinking about when they no longer need a hospital level of care, but perhaps they're not ready to go home to their family home, they need something in between, and that in between, that subacute kind of level, it doesn't exist for folks that have these types of needs. And then I've mentioned, of course, workforce shortages. So often people with this level of complexity, not always, but sometimes will need 1 to 2 staff ratio, or we'll need 1 to 2 and awake overnight staff, things like that, to get to that point of stabilization. And providers are fearful that they just can't reliably staff at that level, and therefore can't meet the child or the person's needs. We've heard from our provider community that they are concerned about the impact of existing regulations when trying or sort of taking a risk to admit that there may be, fears and concerns about if that child, engages in self-injurious behavior or injures others, that there will be, mandated reports and investigations, and what does that mean for them and their future as a provider. So we've certainly heard that as a theme. And then also variation in policies on what's allowable for the use of physical and chemical restraints differs in acute care settings than it does in the community. So sometimes interventions that have been reasonably effective in the hospital, the receiving provider is not regulatorily allowed to keep doing that. Or confusion about what they can and can't do because it is complicated. And then similarly, behavioral health rates not aligned with the cost of care to provide services. So just want to run through some of our current and future efforts at the state to address these really complicated issues. So I've talked a little bit about our DHS Hospital Technical Assistance and Consultation Team. This is a very limited, small initiative with Fairview where they provide lists of children and adolescents that are stuck to our team. This team has, although it is a limited effort, has grown tremendously over the couple years that it's been in place, and includes staff from over 5 different divisions. Usually 45 staff members attend, anywhere between 30 and 45, where they're actually running lists, assigning point people, trying to coordinate between the lead agency, the county, the hospital, the receiving provider, trying to pull away any barriers that we have control of to expedite discharge. So the data that I mentioned earlier, as I said, it was a limited data set. The N is about 90. That information comes from that data set, as well as, of course, the experience our staff have over the years working on difficult situations. Conversations about this particular issue are happening all over the state. The Children's Mental Health Collaborative, led by the Children's Cabinet, they're actually meeting at noon. They meet every month. And I mentioned the Acute Care Transition Council that was authorized this past legislative session. So we are working diligently to get that stood up. The applications for the public memberships are posted and available on the Secretary of State's website. And we are also reaching out to the organizations that have direct appointments to get contact information and names. So progress in terms of getting that stood up is good. We're putting a lot of, or I'll say I'm putting a lot of hope in this council to help us understand a statewide and systemic approach to approach this that also includes some variation at the regional level, because we also know that provider networks differ geographically, availability of staff differ, and so there should be a comprehensive sort of statewide solution, but we also need to be keeping in mind our county administered system and the importance of regional resources and figuring out how to support different regions filling gaps in their communities for service providers. We also have some opportunities to utilize some federal funds through our Money Follows the Person program to do some restructuring within DHS to create better communication flow and alignment. As I said, there are a lot of different conversations going on about this topic, and really seeing a need to harness the energy and get those conversations aware of each other and aligned and working towards concrete solutions together. So we hope that some of this will support that work. And I really breezed through that, but I was sensitive of time, so I'll stand for questions or.
Stick around. Anybody?
Quick question.
Yeah, go ahead, Mr. Chair.
Just wanted to ask, where do children under age 18 transition to? Which kind of facilities are accepting them or providing that care?
Chair Nor, is your question related to kids in transition that maybe are between 16 and 21? Yep, so I think if they're more aligned with the disability services system, they are going into community residential settings, those 245D licensed facilities, or they may be in transition programs for people with mental health. But I would defer to my colleague, Director Grom, on the children's mental health side.
Director Grom.
Mr. Chair, Christy Grom with the Department of Human Services. We do have some limited data on where, I think in general, you're just talking about where are kids going when they leave the hospital, and we do have some limited data from that HTAC endeavor that we do, and we do see some children going to psychiatric residential treatment facilities, but really we don't have enough data to know comprehensively where kids are going to give you the best picture, and so that's something that we need to work on with the advisory council that Ms. Mers mentioned, and with the legislature to see how we can collect better data, because we can't fix the problem that we don't understand, right? So we'll continue to work on that with you.
Well, looking at the data, can we also get the data of how many kids are sent out of state who are being provided care because we could not provide the beds here?
Mr. Chair, Yes, we are working on that. The department is working with our Children and Family Services area, and the legislature, I think, passed some language last session that requires us to do a survey and to work with lead agencies to collect that data because we don't have adequate and comprehensive access to that at this time. I believe we have a survey that's going to be going out in September, and we're on track to meet that deadline, and so we look forward to sharing that information with you once we get it all together and aggregated.
Thank you, Mr. Chair. Thank you, Ms. Mertz. Lots going on, and I thank you for that. We're going to go, Kim Hicks, I think, wanted to have a question, and a Representative Hicks, I don't know if she can hear me. Did she want to jump on? Do you know, most people get really, nervous when systems don't work right, voice systems and video systems, and you watch people get all sweaty and stuff. And it's not bothering me. So can you text her, Ms. Hicks, and say, open up and tell her she gets a minute. If not, I'm going to cut her off. So since she can't hear me, that's kind of funny, right? No. Thank you, Ms. Hicks.
Mr. Chair, I think we can pick up that question later on. We've got guests who are here to testify, so I think we should invite the doctors, all of them, to come to the testify table.
Doctors, come on down. Can we get some more chairs for these folks? How many chairs do you need? 5. She can wait now. I'm sorry. That's sorry about why am I apologizing? I'm not a techie person. I don't understand this. Maybe they should get somebody that understands this stuff, right? I know there's a representative from Osseo that understands this kind of world, but, since she's not saying anything, she's just over there laughing. Welcome to the committee, members. If you could just quickly tell us who you are and where you're from, and then, go ahead and really, you know what the problem is, right? We just need to understand what the fix is. Don't sit there and elaborate on the problem, right? I mean, if you want to, you can. But, I'm sorry that it's taken so long. But, the stuff that we talk about between the House and the Senate, these committees is, it's important stuff. And so I want to give you your due time for that. So please welcome, and you can start.
Chair Hoffman, Chair Knorr, and committee members, my name is Dr. Amy Snevice, and I am the System Medical Director for Pediatric Hospital Medicine and Acute Care at Children's Minnesota. I've been in healthcare for over 20 years, first as a nurse and nurse practitioner, and now as a physician. At Children's Minnesota, our aim is to be every family's essential partner in raising healthier kids. We do this by ensuring families can access the right level of care in the right setting and at the right time. Right now, for too many children with mental health needs, accessing the right level of care feels impossible. For many, their mental health gets worse while they are stuck in the hospital, living in our hospital, waiting for community or residential placement. Over the first 5 months of 2023, the hospitals where my colleagues and I provide care saw almost 1,000 children boarding for a total of 5,800 days. Some of these patients lived with us for the entirety of those 5 months. It's a heartbreaking reality that children and adolescents are not immune to the nationwide mental health crisis, and they deserve swift access to resources designed to meet their individual mental health needs. Today, I join my colleagues here in asking the state to support kids' mental health care by investing in community mental health services and using their regulatory power to hold systems accountable for finding solutions for kids in crisis. Thank you.
Thank you, Doctor. Wendy.
Hello, I'm Wendy Elfert. 14749 River Hills Parkway, Dayton, Senator Hoffman. I'm a registered nurse, and I'm currently the System Chief Nursing Officer for Maple Grove Hospital and North Memorial. As has been highlighted by Amy, we're failing children and their families in our communities. North Memorial is definitely not immune to that. These children have extremely complex healthcare needs, as you just saw described in the last presentation. By not addressing the gaps in resources within the behavioral health continuum, the need for more resources for these children and families, and failing to effectively maximize the current existing resources, these children sit in our emergency rooms with no places to go. This means that our emergency beds are filled with patients for days, and then these beds aren't available to other patients that need them. When these patients get stuck in the ED, we find that we can't flow them through the system. It becomes more and more difficult to find placement for them the longer they're there. Across the system, we have challenges discharging patients when they're ready to go. That's just a common reality for us these days, but this is especially true for our pediatric patients waiting for behavioral health resources. Sitting in an emergency room for many hours and days only delays the specialty care that these kids are in such need of. Between January and May of this year, 70% of the patients boarding in our ED were 18 years or less. When we have pediatric patients boarding in the ED, this is not only the wrong environment for their care needs, but our teams spend hours trying to find appropriate placement for these children and families. Often placement is found several hundred miles from home, and this is the only option we can offer. At North, the average length of stay for our kids boarding in the ED is nearly 5 days longer than it takes us to place an adult patient needing a bed. I understand how challenging this problem is. We want to be part of the solution, and this is why we are here today. Please consider carefully the needs of these kids. They are, in fact, our future generation. Thank you so much for your time.
Thank you. And we had this conversation last year.
Yeah.
And I'm sorry this is still happening. And it's like, it is that systems, you talked about it along the way, and it's like, how can we gather a group of people to fix this system, right? And I appreciate that conversation. Dr. Patel.
Chairs, members of the committee, my name is Dr. Sandeep Patel. I'm a pediatric hospitalist at Hennepin County Medical Center. We're a safety net hospital receiving the state's most vulnerable children. Many are adolescents with mental health conditions or substance use disorders who arrive in our emergency department via Child Protective Services, emergency medical services, or the police. HCMC does not have an adolescent psychiatric unit, and we don't have the ability to board children in the emergency department. We move children as quickly as possible to our medical pediatric inpatient unit. Most adolescents are medically cleared at the time of admission or within 24 hours, but we're unable to discharge the patients because they do not have a bed at a psychiatric facility or, as wards of the state, an area of safe placement. Unfortunately, we're not equipped or staffed to meet the complex social and behavioral needs of this population. Resources are shifted away from other children who were admitted for medical reasons. Due to elopement and safety risks, the adolescents are boarded in a highly restricted setting, deprived of normal activities such as the ability to go outside, to access school, to have peer interactions, or a stable environment. Regularly, they become frustrated as they advocate for their needs, bubbling over to agitation and unsafe actions, which often lead to a traumatizing experience for everybody involved. Families are desperate for their healing. From January to May of this year, 10% of our admissions were for this population, accounting for 25% of our hospital days. Our medical team is doing its absolute best to care for these children, but the system is failing them, and that feeling will affect the children far longer than any hospital stay. Thank you for your time.
Thank you, Doctor. Dr. Lardzabal.
Yes, is it morning or afternoon?
Depends. You can define however you want.
Thank you, Chair and members of the committee. So yes, I'm Mary Beth Lardazam. I'm a child and adolescent psychiatrist and the Vice President for the Mental Health and Addiction Clinical Service line at Allina Health. I've been in practice for 27 years, and 19 years of that practice has been in the great state of Minnesota. Finding the appropriate level of care is really a difficult issue for Allina Health and all of us today. We really appreciate that you're taking care and attention to the impacts of boarding, especially for our child and adolescent patients. However, we have been increasingly raising this alarm for the complex and difficult patients, and we really are urging the state to take immediate action. This year, to date, we've had at Allina over 650 kids boarding in our EDs across our system, including maybe the one you're familiar with, Chair, an adolescent who has been in our facility since February, who, because of his severe aggression, we had to close an entire 15-bed unit for the safety of the patients, that patient, and our staff. Collectively, there is much more work to be done. Some immediate solutions we propose. Number one, staff Wilmer Child Behavioral Health Facility till its full capacity and accept and remove the barriers to lateral admissions to that facility from ours. Create a rapid response system to prioritize the needs of these complex kids that are languishing in our acute bed facilities. We need meaningful metrics to hold all parties accountable and to really move the dial in finding timely placement for these kids. Create a statewide process that's consistent across all counties, not a county-by-county process that can be confusing, inconsistent, and may delay care. Develop and fund adequate supports for our kids with autism. This population experiences a huge gap in their resources. We need to develop comprehensive inpatient, at-home services and actually prevent these kids from coming into the hospital. We look forward to continuing the work with the state and our local partners, but we have to address this problem. And this has far-reaching impacts, not just for our healthcare systems, but our providers and obviously our patients. Thank you for your time.
Thank you, Doctor. Dr. Liu, nice to see you again.
Chair Hoffman, Chair Noor, and committee members, my name is Dr. Lou Zeidner, and I serve as the Vice President of Mental Health and Addiction at mHealth Fairview. My responsibilities include, amongst others, the triage of children, adolescents, and adults with mental health and substance use disorders who come to the mHealth Fairview emergency departments. Thank you for the opportunity to testify today, and thank you for bringing attention to this issue in today's hearing. As you have heard, the scenes that are playing out in emergency departments of our health systems and other health systems across the state are some of the most challenging situations our teams have faced in our careers in healthcare. I've been involved in emergency mental health care for over 40 years, serving patients on some of the most difficult days of their lives. Yet for the first time, these situations leave me with nightmares. I would like to focus on a very specific subset of the children being discussed today. Children with developmental disabilities, often with behavioral challenges, are being left in our emergency rooms for days, weeks, and months at a time. I want to be clear, in most cases, these are children who don't have emergent medical or psychiatric conditions requiring hospitalization. They need a loving home that includes long-term stable support. In short, they are getting the wrong care in the wrong place and often for too long a time. Since 2019, there has been a 140% increase in abandoned minors at mHealth Fairview emergency departments. Since the start of 2022, over 295 children with challenges like autism, fetal alcohol syndrome, developmental disabilities, and aggression secondary to challenges with communication have been left at our emergency departments without a place to return. Unfortunately, the problem isn't getting better, it's getting worse. In each of these cases, a parent, guardian, group home staff, or county worker brought the child to our emergency department and told our hospital that they could no longer care for the child in the current setting. In each of these situations, the group home or setting where the child was being cared for refused to take the child back, leaving them in the emergency department. Hospitals and emergency departments are not designed for these children who need a consistent, low-stimulating environment with complex behavioral support. I want to highlight two cases in particular that are illustrative of the overall problem. Last December, a county worker brought an adolescent child from a group home to our emergency department at Ridges Hospital in Burnsville on a Friday afternoon after the child had returned to the group home from school. The child was left in the ED with all their belongings as the group home told the county and DHS they were temporarily suspending services for the child. That child was forced to stay at Ridges for 2 months because the original group home refused to take the child back and no other facility was willing to take them. More recently, we had an adolescent with complex behavioral issues who lived in our hospital for over 2 months. Our social workers made more than 100 attempts at placement before finding a group home to take that child. Without question, the issue shows the significant gaps in our children's mental health, particularly for this population of children and adolescents who have complex behavioral needs paired with intellectual disabilities or developmental delays. But for the sake of these children, we cannot just wait until the system is built to address this problem. It is inhumane for the child and unfair to the staff who are not appropriate caregivers. We must focus on the solutions that we can implement now to ensure these children are in the least restrictive condition. We have been working on process around this issue for over 2 years with DHS and county partners. But process will not fix this problem. We need actionable solutions now. We have identified 4 key immediate actions requested. Our social workers who are responsible for finding placement for these children need one single point of contact within the state. Counties need to prioritize the guardianship process for patients in acute care hospital settings and prioritize rate negotiations with group homes. Counties who are serving as guardians for many of these children need to prioritize placement for the child who has the right to be placed in the least restrictive setting as soon as they are ready for discharge from our hospitals. And 4, group homes and other facilities cannot be allowed to exploit temporary suspension or services by leaving children at hospitals and then refusing to take them back. We need the licensing authorities to hold facilities and providers accountable. I cannot stress enough the toll that this silent erosion of services and support is taking on these children and our frontline staff. Hospitals are really good at caring for people who are really sick. They are not optimal places to provide long-term residential treatment. We will not abandon these children, but we cannot be the only thread holding up society's safety net. So many of these issues are hampering hospitals and health systems right now, including workplace violence, burnout, crowding, and lengthy ED wait times while waiting for inpatient beds. All could start to be alleviated if we were able to work together on solutions for these vulnerable children. We need your help to ensure that the future of these children is an environment that supports their physical, psychological, and emotional development in the most appropriate, least restrictive setting. In closing, I want to acknowledge that this is a difficult challenge. People talk about it as complex. I'm not sure I agree with that word, but it is difficult, with few easy answers. Yet I know as Minnesotans, we can and we must do better. Thank you for your time today.
Thank you, doctors, and favorite nurse from Dayton, Minnesota.
Thank you.
Thank you. Stick around if folks want to talk. I do know Representative Fisher and Representative Quam actually want to have say comments and have some questions. So I got Representative Fisher first.
Thank you, Senator Hoffman, and thank you for coming forward to talk today. I know that Representative Hicks may want to say something too, and so I'm going to try to not repeat some of the stuff because she and I have been talking about this for a while. One of the things that I am hearing is that, and was brought up by our last testifier, is that a central point for collecting information. I know that one of the issues out there is, as a statewide, we don't know exactly how many kids are in this situation, and particularly how many have already been sent out of state that are being paid for by the counties. I know that I've checked with Ramsey County. They're paying millions of dollars each year, and they usually got somewhere between 20 to 40 kids they're sending out of state. And statewide, we don't have any idea of how that is being put together. So right now, counties are also part of this and trying to deal with it, but it gets very, as you're saying, it's very difficult trying to figure out. And so one of the things that it feels like is part of the problem is that our system here is not built out and has been somewhat neglected. And I think that we should have been having the folks from direct care and treatment here, as I think part of the problem is that they have been woefully underdoing the work with children out there, providing the services out there at some of the more complex levels. When we're hearing that you're boarding children that are having behavior issues, nowhere else to go, feels to me that should be part of the direct care and treatment system as we do for adults. And it feels like that part of the system is somewhat absent or fully underfunded. So I think one of the things that we're looking at going forward is having to focus on the direct care and treatment side, but then also taking a look as what can we do to get a better idea as how many kids that we have that are already disbanded out there, and try to figure out what do we do to bring them back home. Because when you don't have that, the farther you have people from their safety network, the more difficult it is for them to be recovering and getting strong again. And so we need to also figure out how to bring those part of the folks back into our state to be closer to their support network.
You raised a lot of questions that I think we should, if we had a couple of hours here to keep going, but I think we should have an actual follow-up to get, because direct care treatment, we know we all moved to separate direct care and treatment from the department and the obligations there, which makes sense, right? And so this would be something to bring forward, because what are the actual numbers and what is the actual cost? Thank you for bringing that, Representative Fisher. So Sean and Kevin, I know Kevin's back there being the Radio Shack guy. Is there, yeah, he is still back there, right? Maybe as a follow-up in the next couple of months, you find out from members. And then I also have some other dates to give members too. So with that, Representative Quam.
Thank you, Mr. Chair. And frankly, and unfortunately, I've been hearing it for years, it's a growing and burgeoning problem. For several years, I was on the governing board of a special education district. And one of the things that I noticed, because we had several small schools together to have the critical mass to be able to have the programs to work, is that certain things that we did to help develop coping skills, socialization, and options of activities had a huge reward and prevented the escalation or degradation of conditions. And so I like we're bringing to focus what's needed to cover what's happening. But I think we need to focus also on those early intervention and supports with the cooperation of school districts and other entities to be able to decrease the people that reach a level that is so critical. So I hope the committees could maybe grab some information, because best practices, we're talking individuals. So best practices around the state should be shared so they have options that will work with that individual in their case. So I hope the committee can focus on that in the future. Thank you.
And thank you for your time, Representative Quam, and especially serving in that capacity. You saw the obligation of, and this is where every child has a right to a free appropriate public education. It's an obligation to do those services that you talk about in the education world, where, we're talking about these are not mandated, right? But it's sad to hear the population you're talking about doing the proactive stuff in the education world that ends up moving up into now this being housed in hospitals are people with intellectual disabilities or developmental disabilities, and then have that behavioral piece on it. It's like, where is that breakdown, right? And I think you're alluding to that. How do we bring in those partnerships? And maybe part of this conversation, Sean, and you and Kevin are looking at is there folks from the Department of Education in that transitional piece? Because that's the proactive, I almost called him Senator Quam, can you believe that? Representative Quam, Representative Fisher are talking about is, what are we doing to assure our system is supporting that proactively? And I don't know, and I'm sure Natasha Mertz, Assistant Commissioner Mertz and Christy Grom, you probably, your heads already, they're shaking their heads, so we'll get that in here. So thank you, members. I appreciate you being here, and thank you, Doctor.
Yeah, thank you, Mr. Chairman. I want to urge that action is needed.
Yep.
And data collection is critical, and prevention is important. But we have a crisis in the emergency departments, and I don't want to lose that in the timelines of surveys and data collection. I think we need to do that, and we also need to address this problem.
Yeah, you know what, and you're at your 5 points. I actually got 5 from your conversation, not 4, unless you want to share that. But those points are actually in there. And the other thing, members, we have in the Department of Human Services world the positive supports. We have to follow the fact that youth, and in some instances, hospitals end up tasing. You got youth that are being tased, youth that are being restrained, right? And it's like, is that the most appropriate placement for somebody? I believe the answer is no. So to Dr. Liu's point, let's really move that out, right? And then this also leads to a deeper conversation, which I think we should have as a follow-up. There are youth in juvenile detention facilities that are being isolated, kids with mental health that are just being isolated, right? I mean, those are the kinds of things and I think that's our obligation, because we're talking about these are kids with disabilities. So with that, thank you everybody for being here. And yes, this opens up for next session. I look for your stuff being in front of us and working in collaboration. Kim Hicks, can you hear me? Are you on? Can you get us? Can we finally get? We're calling her. So you guys can hang out, or you can go sit down, and maybe Assistant Commissioner Mertz wants to come back up, because I'm sure Kim Hicks will have a question. And if the question is related to you folks, then does that work?
I can hear you now.
All right, handing you to Chair Nor.
Please go ahead and ask the question, Representative Hicks.
Thank you so much, Chair Nor, and thank you, Senator Hoffman, for having this hearing about this crisis. And I want to thank all of our testifiers today who came and really talked a lot about what they're seeing and what the professional piece of this looks like. But I just want to recenter us before we end today back to what this looks like for families. I want you all to just pause for a moment and imagine being a parent and having your child be a danger to you, themselves, or their family, and you go to the emergency room for support, and there is nowhere for them to send your child. And I heard people use the word abandon today, and I want to be a voice for families who are not trying to abandon their children. I want to be a voice for families today who are saying, you here in the emergency room say you can't keep them safe. 100 providers said their needs are too extensive for them to keep them safe. But the expectation is that I should take them home and keep them safe. And so I need everyone to recenter around what this feels like for a mother, for a father, for a grandmother who took guardianship of her grandson because his parent wasn't able to parent. We've heard a lot from the professionals today, and I want to reground us in the families and in the children and what this feels like for them. The department has shared a lot of information about the crisis and all of the work that they're doing, and I want to thank them so much for that work. And our hospitals have shared about all of the things they've done to go above and beyond. But the core of the problem remains that there is nowhere to go. And we need to create that space. But that is not going to be a magic wand that we can wave and suddenly there are people and beds in the right program. It is going to require a collaborative approach that is going to require support from the new Children and Families Department, from DHS in Disability Services and Behavioral Health, but also from DCT, like Representative Fisher mentioned. And so my question to the department is, what are we doing to ensure that we have interagency collaboration, state agency collaboration with MDE, Children and Families, DHS, DCT, to really bring forth a proposal that fills in this emergency gap?
Assistant Commissioner. Thank you, Kim. Assistant Commissioner.
Thank you, Mr. Chair. Representative Hicks, thank you for that important question. I think, as you've identified, the complexity of the systems problem is going to require all different parts of our system, and that certainly includes our state agencies that are charged with serving and supporting these children and adults in various capacities. The Department of Education, the Department of Children, Youth, and Families when it's formed and separated, direct care and treatment. So I can say that we definitely fully recognize that that collaboration and statewide alignment is essential, while we're also paying attention to regional solutions and gaps that might be particular to regions and working with our lead agency partners. We have some models for interagency collaboration in smaller, maybe more targeted initiatives that I think provide a really strong foundation that we can build off of, and that's certainly something that I hope to bring forward as a part of the Acute Care Transitions Task Force. But I think a lot about our work to advance person-centered practices and positive supports post-Jensen settlement, and really working on the positive supports rule and implementing that across our system. We had, for example, give-get relationships with the Department of Education to build out that capacity. We have been working over time with the Institute on Community Integration to set up regional models of implementation that bring together not just state agencies, but county partners, major provider organizations from that particular area. So I think, you know, I can say definitely from the department's perspective, we are fully committed to working across state agencies and working within our current agency. As I mentioned, our HTAC team includes a broad representation from behavioral health and children and family services. And I know that I have had many conversations with my colleagues about the importance of continuing that cross-agency collaboration, because fundamentally these issues are solved for individual patients through multidisciplinary teams to bring the perspective, the clinical perspective from the medical professionals, behavioral health perspective, positive supports, functional behavior analysis, and then implementing and training receiving providers to provide that high level of service and support, and trying to figure out what else do providers need from state agencies and regulators that they're not currently getting to incentivize those admissions, while we're also not reducing standards or creating regulatory loopholes that might put children or people with complex needs at risk.
Thank you, I think she did. She was listening over the phone. We've got crisis in our hand when it comes to this issue. So I think the sense of urgency of now that we need to have action, it's something that is important, and we're hoping the department can find immediate solutions while we work on the long-term solutions. So that's our hope, and hopefully we can get things going, and we can work with the providers, we can work with the families, we can work with those who are willing to do this work. So thank you so much, Assistant Commissioner.
Thank you, Mr. Chair, and members, thank you. I think we should thank staff for putting this on, and I was just schwitzing you about the technology. It's beyond my scope of understanding. So, but Kevin, David, Sean, thank you.
Mr. Chair, I think this
Chair.
is better than the karaoke session in the Senate that happened when when the microphones really failed. I think you forgot about that.
He's slamming us, but it worked. It did work. Members, thank you for being here. This just leads us to wanting to have more conversation. But in light, set aside August 24th and 25th. We're doing a joint, we're going to go on a tour. We're finalizing details of a tour that's going to include disability and elder care services. Dates will be August 24th, 25th. Both House and Senate Human Services Committees will be invited. If you're interested, which I think it would be great to go out, and see regionally in the state of Minnesota, how that looks, the services. Get a hold of Kevin Parker or Sean Herring, and we'll send out the emails that will be sent out to our full committee members with more details early next week. So clear out August 24th and 25th. Don't go to any baseball games. Thank you, members. Mr. Chair, to you.
Well, thank you so much, everyone. I know we extended the time. We apologize because things happen sometimes. So with that, Mr. Chair, we are now adjourned. So thanks to everyone.
Thank you.